and I hope that we can have a discussion about that this afternoon. And next week we'll talk about selections and integration. I'm Dan Rifkin. Thanks for joining us this afternoon. I'm here with Kevin Warling, our Envision IT support specialist, and fondly refer to our venue here as Studio Envision, where we can broadcast this webinar to you. I mentioned that today we'll be talking about the requirements and guidelines for psychopharmacotherapy, and included in today's talk will be clarifying why the word psychopharmacotherapy instead of psych meds or something to that point. And in order to add some depth to our discussion, I'd like to clarify, Carrie, I remember you as being a nurse practitioner at the Roswell School-Based Health Center, is that right?
Yes, that is.
Okay,
and I do want to apologize. I have to leave early. I have to go pick up my kid.
By what time will you need to be leaving, Carrie?
I'm thinking about 3:30 or 3:40.
You know, I might be able to get through our material by 3:35, 3:40. I'll try to move along. And that reminds me, too, if at any point I'm moving along too quickly or you have questions with a group this small, it's really easy to take your questions and comments as they come, all right? And
Great.
Mila, I recall you're with APS?
Yes, I'm a nurse at Chaparral Elementary School.
All right. Mila?
Uh-huh. Can you hear me?
You sure can. Thank you.
Okay.
I think both of you have been with us before, so I think you know that you have the opportunity today to be earning a CME credit for your participation in this webinar. Well, let's consider the psychopharmacotherapy for student depression and anxiety, because medication has become a mainstay of behavioral health treatment. However, students prescribed psychotropic medications and others involved in their care often worry about the medication's safety, question its efficacy, and usually receive insufficient information from providers. And for me, that really raises the whole issue of how therapeutic is a prescription for psychotropic medication if it's raising concerns and worries about safety, efficacy, and basically a sense of not knowing enough about the medication. I think there are therapeutic ways of approaching medication that fit into an overall treatment plan. Students and others involved need to receive sufficient useful information before psychotropic medication is prescribed. And that way the psychotropic medication is part of an overall therapeutic process for the student and others involved. Well, by way of contrast, I'd like to share with you a cartoon that I've appreciated over the last few years. Fillmore portrays a couple talking to the doctor, it looks like, who says, "The bad news is your son's problems stem from too little time, attention, discipline, and affection from the two of you. The good news is we have a pill for that." So I hope you'll appreciate that today's presentation is really the antithesis of that approach and making a much more, hopefully, therapeutic approach to the whole consideration of psychotropic medication. Psychopharmacotherapy is the therapeutic use of psychotropic medications rather than merely psychopharmacology, which is about the properties and actions of psychotropic medications. We'll have a section in next week's installment that I called the medication selection. that will be about the various psychotropic medications used for treating depression and anxiety. Sounds like somebody just joined us. Is that Charlene?
Yes, it is.
Hi, Charlene. Thanks for joining us. Charlene, I need a reminder as to whether you're a nurse with IHS.
Oh, I work with public health nursing. I'm an interpreter and a motor vehicle operator.
I'm sorry, I didn't mean to interrupt. You said interpreter and mentioned something else?
A motor vehicle operator.
Okay, thanks for joining us. Charlene, I've been talking thus far about the introduction to today's talk, which is really about therapeutic uses of psychotropic medication, more than merely writing a prescription, in considering treatment principles and approaches toward making medication a therapeutic opportunity for youth, part of an overall therapeutic process rather than merely a prescription. And I think Carrie and Mila, I don't think you would mind if I reiterate the point that because students as well as their caregivers often worry about medication safety, effectiveness, and a sense of not knowing enough about the medication, that to me alone seems counter-therapeutic. So how we approach the medication and the crucial conversations that we have can make it a much more therapeutic process. So our goal is safe and effective pharmacotherapy for the treatment of student depression, anxiety, and related conditions. And in previous webinar episodes, we've been talking about the identification of depression and anxiety and related conditions in students, primarily because depression and anxiety are fairly common in students. Now we're looking at various aspects of treatment. For today's objective, we're going to list 3 requirements and 5 guidelines for safe and effective psychotropic medication prescription for student depression and anxiety. Our perspective is BioPsychoSocial, looking at the biologic determinants that are genetic and constitutional, psychological aspects, as well as social and other environmental considerations. And I'd like to bring up something that I came across from the popular press in the last couple years. A colleague here at Envision, a nurse practitioner, brought in an article from the New Yorker. I see it's 3 years ago this month, in which the author, Louis Menand, wrote in an article entitled "Head Case, Can Psychiatry Be a Science?" And the author claimed that psychotropic medications, that is, antidepressants, are prescribed merely for a normal response to the human condition, that is, such as sadness, that somebody might experience, or feeling stressed. And the clinical aim we have in considering the topic today of psychotropic medication prescription is to treat a diagnosed condition, such as a depressive disorder or anxiety disorder, not merely a difficulty with coping or feeling sad for a day or part of a day. That we do this as part of an overall treatment plan, and that treatment plan is informed by the clinical assessment. That's a counterpoint that I think Menand did not represent in his article. Well, how do we inform a treatment plan by comprehensive assessment? Well, Wayne Hugo Green writes in his popular textbook on child and adolescent clinical psychopharmacology that psychopharmacotherapy, and he uses that same word, should always be part of a comprehensive treatment plan developed after thorough clinical assessment resulting in diagnosis or at least a working diagnosis. This is consistent with the practice parameters that are put forth by the American Academy of Child and Adolescent Psychiatry. There's one distinction I'd like to make, however. While I agree, and it's very much along the notion of at least a working diagnosis. Psychopharmacotherapy can be part of an overall treatment plan initially following an assessment. Okay? It doesn't yet have to be a comprehensive treatment plan. We need to have at least the beginning of a treatment plan. Okay? We may have a working diagnosis. We need to have enough of an assessment to know that there's a condition that needs treatment. Okay? But it can be an initial treatment plan that we're currently developing and ultimately will become more comprehensive. In this way, I view it being a requirement to have the beginnings of a treatment plan underway before the medication is prescribed, and to include as a guideline for further action to develop a more comprehensive treatment plan. Here are the three requirements that we're going to be meeting when we consider psychotropic medication for a student. That there be a comprehensive assessment and that an initial treatment plan be developed. That there is working knowledge of the state laws pertinent to prescribing psychotropic medication for youth, and informed consent. And I'm going to make some distinctions because informed consent doesn't necessarily mean that there's an agreement to take medication, but merely that we've had a conversation, and it could be that the medication is declined. Well, we've begun talking about how assessment informs treatment planning. We need to diagnose to best determine treatment. Okay? And that needs to consider the presence of both psychiatric and medical conditions, okay? Such as in a circumstance where youth may be overweight and already developing signs of metabolic syndrome, such as evidenced by the presence of acanthosis nigricans while they're presenting with depression and anxiety. That could have a bearing on what we decide to choose for a medication, for example, and what other aspects are part of the treatment plan. We need to consider that other psychiatric disorders commonly co-occur with depressive and anxiety disorders, such as ADHD, as well as eating and/or substance use disorders. And another important aspect of a comprehensive clinical assessment is the establishment of a baseline of signs and symptoms that, once identified, really select the target symptoms to monitor during treatment. And this is very much part and parcel to how we may know that a student is depressed, but depression and its particular signs and symptoms for an individual can be as unique as that individual's depression, which in turn can be as unique as they are. That is to say, every student's depression is different. And it's the predominant signs and symptoms that we want to have a good handle on. And we'll talk about that some more. We also want to be sure that we know the pertinent state laws. Statutory law in our state pertaining to psychotropic medication prescription for youth includes the requirement for informed consent be given before the medication is prescribed. And there is a breakdown by age of student. In other words, if a student is, say, a senior, 18 years old, they can give their own informed consent to be prescribed medication. If the student, on the other hand, is a middle school student in, say, the 6th or 7th grade, under the age of 14, there needs to be the informed consent of the parent or legal guardian. Often we're very much challenged by this rather gray area, if you will, of students who are 14 to 17 years old who can give their own informed consent, provided that the parent or legal guardian has been notified and that they're notified by the provider. Now, there can be some exceptions to that, okay? Such as in an instance where a student is very well informed about the medication. You know that the student has had that conversation with their parent before, and you've been a part of that conversation as a provider. Well, in that case, the provider may not have to contact the parent again, but these things are determined on a case-by-case basis. But generally speaking, it isn't always the same requirement for all youth with regard to age for informed consent. And the informed consent for a psychotropic medication prescription is a whole lot more than signing a consent form. In fact, we really don't even need to have a consent form. We can document, providers can document in a student's clinic record that there has been the informed consent discussion. This is part of an essential process. It's not merely directive in the sense of writing the prescription, giving it to a student with or without their parent or legal guardian, and merely telling them to take the medication. There's an essential process that's involved here that is performed by the prescribing medical provider. It's comprised of the presentation and discussion of the following as applicable before consent is obtained and a prescription is written. Now you'll see that I've got this 4-letter abbreviation. I can't even say it's an acronym. I come up with this. This is the sequence that I often have in mind when going over the information with students and their parents or guardians or other caregivers. Usually talking about indications, following by alternatives, followed by potential benefits, followed by risks or untoward events, which we'll talk about some more in just a moment. We need to talk about off-label prescribing, especially when that's being done, and make the distinction from FDA approved for prescribing. And we need to be able to address safety and efficacy, and going through these steps will assure that we do. So this process of informed consent that I've been talking about is more than merely directions and writing a prescription and commanding somebody to do something. It imparts enough information to impact the outcome in a therapeutic way. This is the second point that's counter to what Menand writes about in Head Case in the New Yorker. The author writes, "The doctor hears your story and prescribes an antidepressant. Do you take it?" Well, if there are questions about whether the medication is going to be taken or not, those really need to be addressed in the session. And I'm talking about, it really behooves the provider to make sure that these questions are being addressed before the prescription goes through the door with the student and others involved. Okay? So as pointed out here, that before the medication is prescribed, the informed consent process literally should provide sufficient information to answer virtually all questions, and that these are sufficiently addressed, and that there is a comfort level with the information. Now, of course, people always will have some degree of ambivalence about a decision that they've made. But by and large, the confidence and the resolve to be committed to the treatment plan really needs to be there before that visit is ended. Well, let's look at that sequence a little bit more of the informed consent discussion, and then I'd like to ask you for some questions. I mentioned a sequence of letters. I've thought about maybe if I had used the sequence of BAIR, I could say bear, and that would be easier, and it would be an acronym. But I find that in my practice, there's a flow of saying indications, that is, why the medicine is being recommended, such as for depression and or anxiety. That there are alternatives, that is to say, the student is not being required to take the medication. They can continue with psychotherapy alone or pursue that if they haven't already. There are alternative treatments, such as herbal remedies, other even nutritional supplements, that there are potential benefits. And I find that and my colleagues find that it makes the most sense to go over those potential benefits and risks or side effects together to compare and contrast. Often it's helpful to talk about generalities to begin with and then get more specific. That generally there are more benefits to side effects of the medication. That if side effects do develop, they usually develop quickly, and therefore we often start with a low dose of medicine. However, youth eventually take doses that are as high as adults do, even though they have smaller bodies, and this is because their metabolism is greater. It's faster. The benefits of most all of these medicines, unlike a psychostimulant like Ritalin used for the treatment of ADHD, can take weeks, even up to a month to get their benefits. But if side effects develop, they usually develop pretty quickly. We usually go over the common side effects because common things are common. And the list of side effects that have been reported, listed on the internet, as well as in the pharmaceutical manufacturer's information, such as that found in the physician's desk reference, usually is a list as long as the prescriber's arm, even with Tylenol and Motrin. So it's really not possible to go over all the potential side effects, and yet it can really guide the student and involved others to help them understand what are the more commonly occurring side effects and other concerns about a medication, so that those can be prioritized over a very rare side effect. Now, there are rare yet serious potential side effects that can occur, and then it's really important to go over those, such as the information that's been in the media a lot about suicidal thinking and other harmful harmful behaviors being associated with antidepressant medication prescription in youth. That's a really important thing to mention, and to have even a brief conversation about, because it's controversial and inconclusive. There also can be another rare instance of a manic activation of youth or any human being taking these medicines. I'd like to ask if there are any questions at this point. I want to assure Carrie and others that if there are, I think we'll still be finished within the next several minutes. Okay. I also mentioned another important point to be considered in these conversations is the notion of FDA approved versus off-label prescribing. And this has a lot to do with the standard of care for youth who are prescribed antidepressant medications for depression and anxiety, because there's not as much FDA approval for youth as there is for adults. For depression, for example, only fluoxetine, which has been known as Prozac, and escitalopram, which has been known as Lexapro, currently are approved by the Food and Drug Administration for pediatric depression. Sertraline, or Zoloft, on the other hand, is FDA approved for pediatric obsessive-compulsive disorder in youngsters, but not for depression. Okay? This is due to the fact that there haven't been sufficient studies to bring about the evidence and make it known to the FDA to gain their approval. Nevertheless, the prescription of these medications has become the standard of care in child and adolescent psychiatry as well as in pediatric clinics. This is referred to as off-label prescribing. I'm going to say it again because of the buzz. I'm going to try to joke with you about this. The buzz about this is that this is referred to as off-label prescribing. Please don't label me as being a jokester about it. We use these medicines all the time. Then how do we do that? Well, there's been safety that's been established. For sertraline, for example, because it's been prescribed to youth who have obsessive-compulsive disorder without frequent problems. We've also found that these medications are useful for adults, including young adults, who have other kinds of anxiety disorders and depressive disorders, and we end up extrapolating from that. So when thinking about informed consent for psychotropic medication, what's required is the discussion. Actually taking the medication is optional. So I urge providers working in school-based health centers to insist on having the conversation. This doesn't mean, we can explain, that the medication does not have to be taken. We merely want you to know that this is an option and make sure that you know that you've received enough information to feel confident about your decision. Okay, that way the best interest of the student is maintained in their care. Well, moving on from the requirements to the guidelines, effective clinical acumen when considering medications include balancing risk with the clinical need or indications, monitoring frequently, identifying and communicating target symptoms, approach the informed consent process as a therapeutic, psychoeducational opportunity for students and others involved, and to develop a comprehensive treatment plan, whereas the requirement involved the initial treatment plan. Well, I want to make sure you know what I mean by balance and monitoring, that we're balancing the potential risk with the clinical needs, such as a severely depressed individual who could benefit from an antidepressant medication? Does their need outweigh the risk that they might have a problem taking that medicine? Much of the concerns about side effects and even rare side effects such as suicidal ideation and harmfulness can be addressed by way of frequent clinical monitoring. Often the problems develop when in a busy clinical practice a prescription is written for several months of medication, which, as you know, would be a month's supply plus, say, 3, 4, 5 months of refills, or a prescription that's filled at a mail order house for 3 months at a time, plus or minus refills. That there be ongoing periodic clinical monitoring, including clinical visits for observation, reports from not only the student, but their parent, others involved, from teachers, that there are regular follow-up visits to assess at reasonable intervals sufficient to determine changes that can occur in target symptoms and the development of any untoward effects. Well, target symptoms I just mentioned, we monitor those. It could be monitoring target symptoms, if you will, as the whole syndrome of how depressed or how anxious one is. However, often in our clinical assessment, as I alluded to earlier, we get a sense of particular symptoms and signs of depression and or anxiety that are very worth monitoring over time, such as insomnia. What kind of insomnia? Trouble falling asleep, trouble staying asleep. Dysphoria, or really unpleasant mood. There might be a loss of interest and pleasure in usual enjoyable activities. Those things can be monitored over time. Often along with those are changes in motivation and energy. We can see if those improve over time. And it's important to identify those to the student and others involved so that they can participate in that monitoring. Now, a colleague wrote and spoke about the so-called 7 deadly sins of prescribing, the definite things not to do, which is, on the one hand, failure to prescribe or treat when there is a definite condition present. And I would say the failure to not have this approach that we've been talking about today. Not setting the target symptoms to monitor clinically during treatment. Not monitoring, not meeting regularly. Starting medications but not adjusting them. Starting medications but adjusting too often, too soon before they can take effect. Setting wrong expectations, such as statements of definite improvement that will follow while taking the medication. We need to find that out with time. And continuing medications that have not been shown to be effective. Well, we've been talking about approaching informed consent as a therapeutic psychoeducational opportunity for students and others involved. And again, that is what needs to be done throughout many of these points that are missed with the deadly sins. In order to develop a comprehensive treatment plan, we want to have that discussion that will also include the point about having psychotherapy along with medication, making sure that health care is maintained, and that there are nutritional and activity considerations for the youth, especially as it's been found, as we know, that these can improve depression and anxiety, and the case management may be able to help with some aspects of the treatment plan. We find that a combination of therapies enhance efficacy. This is consistent with that BioPsychoSocial model. I think I talked about it as an orientation to treatment. This addresses comorbidities such as overweight or metabolic syndrome. we find that integrated care is efficacious, and that insofar as the medication plus psychotherapy usually is superior to either one alone for the treatment of depression, anxiety, and other conditions. This has been posited by the American Academy of Child and Adolescent Psychiatry, for example, although they do recommend starting with talking therapy alone for the treatment of depression and anxiety. The combination of psychotherapy and medication therapy has been increasingly considered first-line effective treatment for adolescent depression and anxiety, especially when it's severe. And that we need to make sure that we're not prescribing the medication alone without psychotherapy. A frequently referred to study is a bit redundant in that TADS, the S on TADS really stands for study, the Treatment for Adolescents with Depression study, found that there's a greater efficacy for fluoxetine or Prozac along with cognitive behavioral therapy than either one alone. And this really pertains to the acute or early phase as well as continuation phases of treatment. You may also hear people say that the TAD study showed that there really is no difference. Well, both are true. Way out a couple years or a year and a half after treatment, the effect of cognitive behavioral therapy alone is about as good as the combination with medication and therapy. But it's during that early phase and continuation phase where the combination is superior. And that's important when we consider that the risk for suicidal ideation and perhaps actions or other harmfulness is greatest during the acute phase. So in summary, psychotropic medication prescription requires comprehensive assessment and initial treatment planning, a working knowledge of the state laws pertinent to prescribing psychotropic medication for youth, and informed consent. Our guidelines tell us the importance of balancing risk with clinical need, monitoring frequently, identifying and communicating target symptoms, approaching informed consent as a therapeutic psychoeducational opportunity for students and others involved, and the importance of developing a comprehensive treatment plan. So with that, I would say, Carrie, if you need to be going to pick up your child, I entirely understand. But if anybody has any questions, thoughts, concerns, comments, beliefs, even protests, please state them now.
Okay, thanks. I thought that was a really great presentation.
Well, thank you, Carrie. I appreciate that. I hope that you'll let me know if there's any aspect of that that you want to talk about further, such as through telepsychiatry consultation. Please consider joining us next week, and I say that to everybody when we'll take a look at the medications and how they may be utilized in a team effort, actually, and not just based on an individual provider's prescription. So thank you.
All right, thanks. Bye-bye.
Bye-bye. So next week we'll have selections and integration, and that will again be on Monday and Tuesday afternoon. It will be repeated on Tuesday. So thank you very much for joining us this afternoon. Carrie, Charlene, and Mila, I really appreciate it.
Thank you.
Thank you.
Dr. Rifkin, I do have one quick question.
Yes.
What does IPT stand for? It was on the slide with CBT. Is it CBT or IPT?
Interpersonal therapy.
Okay.
Interpersonal therapy and cognitive behavioral therapy have the most evidence base of effectiveness of the psychotherapies for adolescents and younger youth.
Okay.
Sure.
All right. Thank you very much.
Yeah, thank you. Any other questions?
I think I'm good till next week.
Okay, sounds good. Thanks for joining us today.
Thank you. Bye.
Thank you. Bye.